What I'm going to present is a research which was conducted between 2016 to 2019. We have just compiled the results. It was a big research, so I've just picked one of the objectives that I thought was correlating with the theme of this Ecsacon conference. So the title is Capacity of Communities in Addressing the Social Determinants of Health. This was a case of Suba sub-county in Nyanza. Suba sub-county is in Homa Bay County. The outline, I'm going to go through the introduction and background, problem statement, methodology, key findings, conclusion, and recommendation. So introduction. Community capacity is the interaction of human capital, resources, social capital within a given community that can be leveraged to solve collective problems, to improve or to maintain the well-being of a given community. This actually depends on the ability of the community to access the social determinants of health. And what are the social determinants of health? The social determinants of health include safe, clean water and environment, appropriate shelter, food, education, income, social capital, and access to healthcare. So the problem, the ability of the community to is facilitated by the socio-economic situation, policies, system, structures developed to address health and health-related issues and affect the health of individuals. Networking, multi-sectoral collaboration, holistic approach to healthcare is essential. Currently, the community resourcefulness falls in both formal and informal sector. It is formal, that is in the sense that we normally have community-based organizations, and most of the time these community-based organizations are gazetted by the Department of Social Services, that is DSS 2014, hence the authorities, they have the authority to regulate the CBO's operation. On the other hand, it is informal. And why do we say that it is informal? Because in terms of engagement, most of the community activities are not legal, legally binding. The wages and the hours of work are not fixed, as in the case of a formal sector. So therefore, the objective of this study was to assess the existing capacity of the communities to address the social determinants of health. And as I've said, the social determinants of health are conditions in which people are born, grow, work, live, and age. And the system includes economic, social, political systems, and policies. We have the community health nursing model. And as we have been talking, community health nursing is core when we talk about community health services. And what does it entail? It entails assessment. And what is this assessment all about? Assessment is assessing or using the nursing process. In a patient, we normally use the nursing process, and it is the same also within the community. And we are actually expected, and this is from the American Nurses Association. Actually, we are expected to assess the community, and we normally do it, that is the community diagnosis. So we have to go through the process of assessing that community, know the history of the community, the culture of the community, the practices of that particular community. After that, then we should be able to come up with a community diagnosis or nursing diagnosis. And our nursing diagnosis, as opposed to that of the patient, within the community, we will look at wellness diagnosis. What have you observed about the community able to keep up with wellness? Like, for example, if you find that the community is no longer a walking community, they are all the time in their PCOS. So that is actually pointing towards lifestyle diseases. And these are some things that community health nursing should be able to address at that particular time. Then we are also able to diagnose illnesses, or when it comes to the nursing diagnosis, what do you diagnose when there is an illness? Because when we are talking of a community, we are talking of households, we are talking of families, and within a household, we have the different age cohorts that the community health strategy has laid out very well. We have 0 to 5 years, we have the pregnant mothers, we have the adolescent in the house, we have the elderly, we have the sick, we have also those ones with mental illness. So within this household, there's a lot happening. So at that community level, what are you able to diagnose at that household level and come up with a community with a diagnosis, and therefore you plan and implement the plan. And when we are also looking at the nursing intervention, we are talking about direct care, we are talking about counseling, we are talking about treatment, we are also talking about collaboration, we are talking about networking, health promotion, disease prevention, we are also talking about health maintenance, and all those factors when we are now carrying out the intervention. And then we keep on doing the evaluation. So this model was very, very useful in this particular research, as even we are going to see as we go on. So the methodology, what methodology did we use? It was a descriptive cross-sectional study design which was used to investigate the problem. It was very difficult because at first we were looking at we wanted households with vulnerable children. And in this study, the vulnerable children are children who are at risk or who are exposed at risk compared to others. And it's very interesting because poverty and all those factors actually pose vulnerability to our children. And this made us now to do a whole household survey in 5 villages in 3 sub-locations, because when we used our checklist, and our checklist was mainly looking at some of those social determinants of health. We were looking at the state of latrines, the kind of housing, the water points that people are using, and it is almost like everybody is vulnerable in that, is vulnerable when we look at it. So qualitative and quantitative methods of research were applied, and the research was carried out at 2 levels. The first involved quantitative research through household survey, that is what I'm talking about. 647 households were identified, and these 647 households included 246 vulnerable children. We had to categorize them, so these were mainly orphans, children living with disability, and those ones with chronic illnesses, and also those ones who are under the care of household heads who are poor. So methodology, vulnerable children, so the level 2 involved qualitative research using observation checklist. And in the observation checklist, we were focusing on the human behavior, physical and material resources, such as the state of housing, latrines, road to health card, to check whether the children were immunized and what their weights were like, and other health records, like if they have been sick, those booklets or the books that they were used, and what kind of illnesses the children were being treated for. So focus group discussions were also applied, and key informant interviews were also conducted. Descriptive and inferential statistic, chi-square, was used to analyze the quantitative data, whereas the qualitative data were thematically analyzed, and they were used to complement the quantitative data. The findings. 65% of the houses were temporary structures with poor lighting and ventilation. 99% of the households used unprotected and untreated water. 97% of the households used open air for defecation. Food harvested during the Nini harvest only lasted, in 92% of the household, only lasted for two months. So the chi-square tested statistically confirmed significant relationship between the cases of morbidities such as malaria and sanitation was found to be statistically significant, as you can see. Diarrhea, clean water, and environment was also statistically significant. Acute respiratory infections and status of the houses were also found to be statistically significant. Malnutrition rates among 0 to 5 years were underweight, 54%, stunting growth, 43%, wasting, 60%. Immunization coverage, 40%, and 58% of the household heads earned less than $1 per day. Community involvement and participation were reported to be inadequate by 58% of the respondents. Another 42 stated that communities are disregarded within sectors that provide services to children, and there was no link between households. Most of the house sectors provided services based on what they think is best for the community, and this was actually reported by a key informant. The biomedical model is still dominant in addressing the health issues, and there was also no technical supervision at community and household level. So in conclusion, communities have inadequate capacities to address the social determinants of health resulting to ill health. As a result of household and community inabilities to get access to technical services to address social determinants of health, and also due to weak structures and systems for community health services and insufficient implementation of the existing policies. Recommendation. One of our recommendations is to develop the capacities of communities, a model that utilizes both the biomedical and social aspects of health to address the social determinants of health is essential. Therefore, there is need for us to review our community health nursing curriculum, strengthen the system and structure for community health nursing practice. Policymakers and health leaders need to assess the healthcare system by identifying the bottlenecks of the interprofessional education and collaborative practice at the community level. Advocating for strengthening of community health system and structures is key. Thank you for listening.